We have a lot, numbers going up. We're close to 60 now on the call. So I'd like to get started and take this opportunity to welcome you all, council members and guests, to our Council on Linkages between Academia and Public Health Practice meeting this afternoon. Kathleen is starting up on the slides. There you go. And Kathleen, if you would perhaps give us some tips for how we're going to be doing things today.
Absolutely, if I can get myself off mute. So thank you all for joining us. As always, we just run through a few housekeeping items as we get started. So as you noticed when you came in, we have everyone muted as they enter the meeting. We ask that you please just keep your audio on mute when you're not speaking to help reduce any background noise for everyone. But we do hope you'll jump in when we'll have lots of breaks for questions and discussions and things like that. So please do feel free to raise your hand and jump into the discussion. We do have audio set up 2 ways. So if you have any trouble with your computer audio, which is probably the default for most of you, there is an option to call in over the phone. So you can toggle back and forth between those if either one is not working properly. Please feel free to have your camera on to engage with us in the discussion. And also please feel free to use the chat box throughout as we go through the meeting today to share questions, comments, or anything you'd like to share. We are recording this meeting, again, as you probably saw when you came in. So we do this primarily for our note-taking purposes, but we do post the meeting online, so it is publicly available. The recording is publicly available, much as the meeting is open to the public, for anyone who misses it or would like to catch up on it afterwards. We do have a copy of the slides available as well, and I think Grace will drop those in the chat box. So if you want to hold on to a copy of the slides, you'll have those. And if you have any issues with any of the technology or anything as we're going through the meeting today, please feel free to put that in the chat box as well. And Grace, who is the PHF webinars account, can help troubleshoot. So you can either just drop that note in the chat box or reach out to her, message her directly through there. So I think that is it for the housekeeping. So Bill, I will turn it back to you.
Thank you, Kathleen. I would like to, of course, because we have a number of guests, many of you may be on your first call with us. So we'd like to remind folks of just who the council is. And I should tell you first that many of the council's activities are supported by the CDC's Center for State, Tribal, Local, and Territorial Support. And our activities then are listed here on the slide in front of you. So as you can see, our major effort is to improve performance of individuals and organizations within public health. And we do that by trying to assist with collaboration among academic, practice, and healthcare communities, promoting public health education and training, and developing and advancing innovative strategies. The council brings together 24 national organizations now. The number's been steadily growing. And you add, of course, the staff from the Public Health Foundation to that. It gives us a sizable group of interested individuals focusing on workforce development initiatives that we hope will broadly benefit the public health and population health workforce. Now, the agenda for today's meeting has been made available to you ahead of time, and it's here up on the screen. It's fairly straightforward. I want to, however, take this opportunity to see if anyone on the call has an agenda item they think should be added to the list in front of you. All right. Hearing none, then I'll assume that the agenda is acceptable to all of you. We've also shared with you the minutes from our last meeting, which was just a couple months ago now. So let me ask if we can have a motion to accept the minutes as presented to you.
Chair, I would so move and also acknowledge the succinctness and also the directness of the minutes as issued to us.
Very well. Thank you. Thank you, Dr. Gilmore. Do we have a second? Would a council member second it?
I'll second it, Lori Edwards.
All right. Thank you so much. Now let me open it up to see if there's any discussion. Does anyone have any additions or corrections to the minutes from September 29th? Hearing none, I guess that's testimony to Dr. Gilmore's comment that the minutes seem to be accurate and appropriate. So let me ask then for a vote for council members. All those in favor, please indicate by saying aye.
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 Wonderful, thank you. Are there any opposed? And do we have any abstentions? Hearing none, then the minutes from our previous meeting have been received and approved. Thank you all for that. Now we can move into our agenda, and I'd like to call on Kathleen, if she would, to give us a little bit of an indication of last year's efforts undertaken by the council. Kathleen?
Thank you, Bill. So as Bill mentioned, we wanted to just start off with a little bit of a recap of what's been going on. This is our last Council on Linkages meeting for the year. And as mentioned, the council has, for the past 30 years, the council has really been focused on building public health infrastructure, particularly around workforce development. And this has shaped the variety of activities that the Council on Linkages has engaged in over the years, with current council initiatives focused in two primary areas: the Academic Health Department Learning Community and the Core Competencies for Public Health Professionals. So Ron's going to be talking or leading a discussion in a little bit about where we go from here. So we thought to sort of start that off and set the stage for it. We talk a little bit about where we've been and what's been up over the last year. So let's see if I'm capable of slides at the same time. So we wanted to just start this off with a kind of a brief recap related to the Academic Health Department Learning Community. So as those of you, many of you have been here many times before, and you've seen this slide 1,000 times, but just for anyone who's new, a reminder that the Academic Health Department, or AHD Learning Community, is a national community that brings together practitioners, educators, researchers, and others to really explore the idea of an academic health department partnership, which is a formal partnership between a health department and an academic institution. So this community brings people together to share their experiences, to learn from each other, and really to explore this area. The learning community offers a variety of resources and activities to its members, as well as to others in the public health community, that are all aimed at supporting the development, maintenance, and expansion of AHD partnerships. So this includes things like providing a venue for sharing examples and stories of AHD partnerships. We have webinars that feature AHD partnerships, create or collect resources, so things like partnership agreements, the actual legal agreements that organizations sign, because we often get asked for examples of those, a listserv to enable communication among learning community members, and then we are also always available to provide technical assistance or any kind of support as people are working in this area. So the learning community is open to anyone who's interested in participating in it. And it has continued to grow over the past year. So we're currently sitting at about 1,500 members from health departments, academic institutions, and other types of organizations from all across the country. And this has been really, I think, it's been really fun for me because I've been involved in this project the entire time it has existed. But I think back to 2011 when we started and we had about 80 people. And so it's been really incredible to watch that growth over the years. In addition, the learning community maintains a list of AHD partnerships on the council website, and this was started as sort of an effort to increase awareness about AHD partnerships, AHD initiatives across the country. And that list continues to grow as well. We now have more than 100 partnerships on that list. I'm sure there are many, many more. So if your organization is part of one of these partnerships and you're not already on that list, please feel free to reach out to me, and we're happy to update that to add your information. Ooh. Okay, here we go. So again, for those of you who've been to these meetings previously, you've seen some of these types of graphics before, but we do continue to track metrics related to engagement with the AHD Learning Community, including both the resources that people access online as well as technical assistance that is provided. So, so far in 2022, I realize we have 1 month of the year left. The learning community and its resources have been accessed online more than 8,500 times, and this brings total usage over the lifespan of the learning community to more than 84,000 visits. We also have continued to provide distance-based technical assistance over the years related to AHD partnerships. And this year so far, we've responded to 18 requests serving 14 organizations in 12 states as well as DC. We have also continued our academic health department webinar series that was started several years ago to kind of, again, focus on AHD partnerships or highlight topics related to building and sustaining these partnerships that might be relevant to individuals and organizations who are working in this area. So we did have 2 webinars again this year. The first one was in February, and it was entitled Envisioning and Building the Public Health Workforce of the Future, the Critical Role of Partnerships. And so that webinar featured speakers from the CDC Foundation, as well as the University of Alabama at Birmingham School of Public Health, and the Massachusetts Academic Health Department Consortium, who really shared their experiences and thoughts about how AHD partnerships have enhanced the response to COVID-19 in communities across the country, as well as how those partnerships can help strengthen health departments as we envision and build the public health workforce of the future. In November, so just earlier this month, we tried something a little bit different, and we hosted our first Ask Me Anything type of event related to academic health department partnerships, which was a really informal opportunity for participants to just join and ask us, pepper us with any questions they would like to know related to academic health departments. So that was a really fun experience as well. We had a lot of participation, a ton of questions, and a lot of engagement and good advice shared, I think, from everyone who was in attendance. And across those 2 webinars, we had nearly 500 participants join us for those events. Earlier this year in April, we also participated in a webinar hosted by the American Association of Colleges of Nursing. So we were invited to join a webinar to give a little bit of background, a little bit of introduction to the idea of academic health department partnerships. And that webinar really focused on these partnerships involving schools of nursing. In addition to webinars, we've also participated in a number of conferences over the course of this year. So starting with, so we did 4 sessions at conferences, starting in May with a kind of introduction to academic health department partnerships type of session that we did at the Missoula Academic Health Department Conference, which is in Montana. And then in June, we offered a virtual session at the 2022 Public Health Improvement Training, or FIT, as many of you may know it. This again was focusing on, kind of envisioning the workforce and how do partnerships play into that. And this featured the AHD partnerships of the Jefferson County Department of Health in Alabama. We followed that in July with a live stream session at the National Association of County and City Health Officials 360 conference. Again, a similar type of session, thinking about where we go from here, and this time highlighting both the partnerships of Jefferson County Department of Health, as well as the partnerships of Granville-Vance Public Health in North Carolina. And then earlier this month, we were at the American Public Health Association 2022 annual meeting, where we did a number of sessions, one of which was really focused on the work of the Council on Linkages and the role it plays in strengthening the public health workforce, and that included a variety of updates and information about academic health department partnerships and the learning community. So as always, I know we say this every time, but there's lots more information about the learning community on our website online, or feel free to reach out to me if I can help you find anything, or if you have any questions or things like that. And I will just pause for a minute before we talk about the core competencies to see if anyone has any questions related to the learning community. Oh, and I see there is one question in the chat, Dana. Recordings of the webinars available? Yes. So we record for the AHD webinars, we record all of them, and they're all available on our website. And maybe if Grace would be so kind, maybe she can drop the link in the chat box for you, because you can find them all there. The most recent one that we just did, was recorded. It's not yet on our website. It's almost done. We just need to publish the page essentially. So that will be there shortly. And yeah, Kelly.
Hey, Kathleen, thank you. That was really helpful. I'm just wondering, can I reach out to you? I think this would be really great information for our membership as well. If we wanted to do an audience in 2023, a webinar, excuse me, in 2023, can I reach out to you to talk about that?
Yeah, that would be awesome.
Awesome. Great. I'll do that then. Thank you.
Thank you. Oh, and Grace just put the link to the webinars in the chat. So all the archives are there. And as I mentioned, the one we just did a couple weeks ago will be available shortly. Any other questions? Okay, we will continue our whirlwind tour. And if anyone has any questions, feel free to drop those in the chat and we'll get to them when we break the next time. So we also wanted to just review the year related to the core competencies for public health professionals. The core competencies, again, for anyone who's not familiar with them, are a set of competencies designed to reflect foundational or cross-cutting knowledge and skills for anyone working in public health, whether you're working in public health practice, education, or research. And these have been a high priority item, or something we've talked a lot about over the last little while. The core competencies have been around for more than 20 years now. They first came out in 2001. But they are regularly revised, and we completed the most recent revision at the end of 2021. So that has been, an ongoing discussion point for the last several council meetings. The core competencies are used in workforce development activities across the country. And so there's a lot of work that goes into that revision process, and we're heavily supported in that process by the core competencies work group, which is made up of about 120 members, again, from health departments, academic institutions, and other types of organizations all across the country. And Amy Lee and Jenna Place, who are both on the call here today, are our co-chairs, do a great job co-chairing that work group. So since the revision was finished at the end of 2021 and the core competencies were adopted by the Council on Linkages, we have been focusing primarily on providing support over the last year for implementing this new version of the core competencies. So just a quick reminder here of what core competencies use looks like across the country. So the most current data that's available shows that about just over 80% of state health departments, about 60% of tribal health organizations, 45% of local health departments, a quarter of the territorial health departments, and a majority of academic public health focused programs. That includes both schools, programs of public health, as well as community or public health nursing programs. And all of this data is collected on a regular basis. And through these efforts, we also know that the core competencies are used in a variety of ways to support workforce development. So things like developing job descriptions or performance objectives, engaging in workforce competency or needs assessments, developing education and training, putting together workforce development plans, as well as they often form the foundation for a number of other sets of discipline-specific competencies or tools and resources that support professional and workforce development for the public health workforce. We always like to just highlight this as well, how the core competencies kind of play into some of these major national initiatives. So things like Healthy People and accreditation. Healthy People, the core competencies have been integrated into Healthy People for decades. But in 2030, there are objectives within the public health infrastructure section that really focus on increasing the proportion of state, local, tribal, and territorial public health agencies that use the core competencies in continuing education for their personnel. Within the realm of accreditation, both the Public Health Accreditation Board and the Council on Education for Public Health have used the core competencies. The Public Health Accreditation Board, in its accreditation standards for health departments, incorporate the core competencies into Domain 8, which is the domain that focuses on workforce development, and specifically Standard 8.2, which addresses the creation or requires the creation of a workforce development plan that includes an assessment of current staff capabilities against an accepted set of core competencies, with the core competencies for public health professionals being given as an example of a nationally recognized model that can be used for this purpose. For schools and programs of public health, CEEP used the core competencies in developing its foundational competencies that you see in those accreditation criteria. And the core competencies are also integrated into the Train Learning Network, which is the largest learning networks designed specifically for public health professionals. So we currently have more than 4.2, I think Ron will correct me if I'm wrong, over 4 million learners using Train. And so having the core competencies integrated there offers an opportunity for course providers to be able to communicate to learners what type of knowledge and skills their courses will help build, and then for learners to be able to go search for courses or look for trainings in specific areas that will build specific competencies. And of course, the core competencies have long been designed to reflect the knowledge and skills that are needed to deliver the 10 essential public health services. So that's a really direct tie as well. So again, similar as with the academic health department learning community, we look at a variety of metrics related to engagement, so usage, requests that we receive, things like that. So far in 2022, the core competencies and the resources and tools that are designed to support implementation of that competency set have been accessed online more than 88,000 times. And so this is made up of more than 46,000 visits to the core competencies, as well as an additional more than 41,000 visits to resources and tools. We also, since we recently released the new version of the core competencies, have been tracking access specifically to that web page since that was released. And we've had more than 53,000 visits so far. So that is from November 2021 till now. Again, we regularly respond to requests for technical assistance for assistance related to the core competencies. And so far this year, we've responded to 42 requests serving 30 organizations in 17 states, DC, as well as Tanzania. And as I mentioned a second ago, the core competencies are used or help support the development of a number of other competency sets. And as staff to the council, we're always happy to engage with organizations that are working on these efforts and share anything that we've learned working on the core competencies that might be useful. And over the course of this year, we participated in 2 working groups supporting the development both of a set of racial justice competencies for public health professionals that you heard about at the last council meeting and was recently released by the public health training centers. So that's a really exciting development, as well as the updating of the applied epidemiology competencies, which is underway by the Council of State and Territorial Epidemiologists. And we shared that, I think, not the last council meeting, but maybe the one before. We have talked about that at council meetings before as well. The core competencies were also highlighted in a recent post on the PHF Pulse blog in October by the University of Wisconsin-Madison School of Nursing, which focused on the new to public health residency program, building core competencies for public health practice. So it talks a little bit about how they use the core competencies in evaluating that residency program. So as I mentioned, and everyone knows at this point, the 2021 core competencies were adopted by the Council on Linkages in October of last year. And so they have been available through the council website since November of 2021. And since that time, we have engaged in a variety of dissemination activities. We'll talk a little bit more about webinars and conferences in a second, to try to ensure that the public health and population health community are aware of this new version of the core competencies and have access to this new version for their workforce development efforts. We've also continued to work on updating and developing resources and tools that support individuals and organizations in using the core competencies. So I think we have discussed all of these at previous meetings, but just wanted to kind of recap, highlight in one place several of the updates that took place this year. So we did start our updates with the competency assessments for public health professionals that have been provided for many years. This is the tool that by far we've received the most requests for in terms of people like really waiting for a new version. And so we did start here. We do have versions of these assessment tools that reflect the 2021 core competencies available on the council website. So there are actually 4 assessment tools available. One that uses just the competency statements in the core competencies, and then one for each of the 3 tiers within the core competencies. The 2021 version of the core competencies is also made available on the Trained Learning Network as a search filter. So as we just talked about, this really allows course providers to communicate with learners about what competencies their courses will help build, and then for learners to be able to locate trainings that will help them develop in specific areas. And the most recently completed one was an update of a competency prioritization tool that is designed to support organizations in identifying the most important core competencies for different public health jobs within their organization. So this is really to help determine where to focus competency development efforts. And this tool was recently updated as well to reflect the 2021 core competencies. And we just managed to put it online, so that's now publicly available also. So the tool itself contains facilitation materials for conducting a workshop-based kind of prioritization voting process to prioritize core competencies. And so online you'll find both instructions as well as worksheets and voting kind of templates for capturing results and things like that. As we continue to work, this is an ongoing effort. We continue to work on updating and creating resources and tools. So we will continue to share those as we've been doing through the Council on Linkages update, as well as posting those on the council website as they're completed. And finally, we just wanted to mention the webinars and conferences that have occurred this year, as we have engaged in a number of those as well. And this has been particularly, as you can see from the titles of many of these events, particularly around sharing information about the new version of the core competencies and what's changed, what you see in the 2021 version. So the core competencies were featured at 4 webinars or virtual meetings, and these included a webinar in February. We're invited to participate in the Region 2 Public Health Training Center's Log In to Learn webinar series. So we did a webinar with them. The Public Health Foundation and the Council on Linkages hosted our own webinar in March. We had done a similar one at the end of 2021, but another opportunity for people to come learn about the new version of the core competencies. We participated in a virtual meeting of the network of the National Library of Medicine's Public Health Collaborative, also in March, and then also in March, a webinar with the National Indian Health Board. They have a Tribal Accreditation Learning Community webinar series, and so we were invited to give a presentation there, which was a lot of fun. And altogether across these events, we had more than 1,200 participants join us to learn more about the new core competencies. The core competencies were also highlighted, sorry, this is kind of a crowded slide, but highlighted during 7 conference sessions this year. So again, starting at the very beginning of the year in January, we participated in the 2022 Open Forum, Next Generation, to share some information, to share the new competency set. We engaged in 2 sessions at the 2022 Public Health Improvement Training in June that featured the core competencies. One on building a strong workforce development program, kind of a foundational workforce development session, as well as a second focused on reinvigorating workforce development programs, which we did in collaboration with the Public Health Institute at Denver Health. We did an on-demand session in July for the 2022 NACHO 360 conference, again in collaboration with the Public Health Institute at Denver Health. And then earlier this month, while we were at APHA, again, 3 sessions that included or shared content related to the core competencies. The kind of general counsel on linkages session that I mentioned earlier, as well as 2 other sessions, one focused on tools for using the 2021 version of the core competencies, and another focused on advancing health equity with the core competencies. So again, similarly to the learning community, you can always find more information about the core competencies online, or feel free to reach out to me. I'm happy to help. And I will pause to see if there are any questions right now.
Kathleen, there is one in the chat box.
Okay.
About a comparison of the most recent core competencies with the changes. And it was asking if that's on the CDC site. Maybe I'll ask you to address that, Kathleen.
Yeah, so well, maybe Ron wants to address it because he's working on it at the moment. Yeah. So as far as I know, and Liza, you can jump in and tell us, I don't believe there's any information on the CDC site that highlights this, but we are building, it's been slower going than we had hoped, but a crosswalk that shows how essentially highlights the changes, what's different comparing the 2014 version to the 2021 version of the core competencies. So you'll be able to see how the competency statements transformed from one place to another, and what's entirely new this time around. In terms of some general kind of comments, I think in several of the presentations, and we could, I don't know, Grace, if you have this at your fingertips, we have an archive of one of the intro webinars, and there's slides associated with that as well. And it highlights some of the major thematic changes, like we had a lot of emphasis on really centering and better integrating health equity. There was a lot of emphasis on communications, building out more communication skills, competencies. Finance and management was another area that changed pretty significantly. And probably the most major change in terms of just looking at the core competencies is that we pretty dramatically changed the structure of the core competencies. So it's formatted quite differently than it used to be. So if that helps a little bit, we can definitely, if Grace doesn't have that link right at her fingertips, I'm happy to send you the link to the slides that kind of give sort of an overview of what changes happened, and follow up when we have the crosswalk done as well. And Liza, I saw you raised your hand, so if you want to jump in on this.
Yeah, well, I just wanted to add, obviously, I think everyone on this call knows PHF puts a tremendous amount of resources on its website to support use of the core competencies and to highlight the content. And what we're trying to do with the CDC site is not reinvent the wheel, but to obviously, push folks to wherever the best site is. So we're not trying to duplicate resources. If there are big things that we should highlight that do exist on the PHF site, we can kind of feature that a little bit more. So we could probably pull out a quick mention of the big updates, but for now, what we really do is focus on the fact that, they were most recently updated and here's where you can find them, but there you have also a long history. We do also mention a lot of other competency sets at the bottom of that web page, and we there have highlighted whatever that latest edition might be, whether it's an updated edition or, you know, the one and only release of that particular competency framework. I know many of you are involved with different competencies, and if you think we missed one that you think belongs on that list, please feel free to reach out to Adrian Gill or me, and we'll consider that. We were trying not to make that be a laundry list of every competency set available everywhere and anywhere, but you know, some of the more commonly used ones. But we certainly want to make sure it includes some of the, you know, the latest and greatest or most prominently used ones. And in fact, the racial justice competencies were, of course, the, you know, one of the ones that got in right before we were able to publish the website. So thanks.
Thanks, Liza. Magali has a question in the chat about the session Advancing Health Equity with the Core Competencies. So is there a recorded version of that? I believe the answer to that is yes, because I think that APHA recorded everything. I do think my understanding, I believe I would have to double check this, but I believe the way it works is if you were registered for the conference, you can access the recordings. If you had not registered for the conference, there's usually an option to pay to access the recordings. We have the slides if those would be helpful, so I'm happy to send you a copy of those if that helps at all. So I'll follow up and do that. And Peg, will there be a crosswalk of the 2021 core competencies with the 10 essential services as with earlier versions of the core competencies? Yes. So that is on deck as soon as Ron finishes work on the 2014-2021 crosswalk.
Thanks, Kathleen.
Yeah, you're welcome. No, but seriously though, yes, that is on our list. And once we have the 2014-2021 crosswalk done, we'll be looking to update that 10 essential services crosswalk as well. Because those will
And Kathleen, there are also been requests to crosswalk with the foundational public health services.
Yes.
So that's another.
Also on the to-do list.
Yeah.
And Mighty put a note in the chat that is correct. So there is an option to access those even if you did not attend the conference itself. So that's awesome. And yes, Magali, I'll send you the slides as a starting point, and you can go from there.
Kathleen, a quick question. I was impressed to see another country requesting information about the core competencies, Tanzania. And I'm wondering if we get that kind of interest and access outside our own boundaries. I think it's a very interesting area, and I wouldn't ask you to necessarily get into what the request was for, but are we seeing greater activity, perhaps because of pandemic issues, et cetera?
That's a good question. So we've always, it's not nearly as common as questions from like within the US, but every year we get a handful, and I feel like that's been kind of consistent over time. I can think of China, Japan, Singapore, Ethiopia, like a variety, the UK, Canada. I actually realized after I put all this stuff together that we met with a team in Canada that's looking to think about starting the process of revising their competencies as well. So I should have added them to the list too. But yeah, I don't know if it's more than usual, but it does happen. Definitely like a handful every year. And a lot of it is either, so I feel like there's a couple different kind of categories. I won't name specifics of any particular request, but requests that get at people working on their own, or the countries working on their own competency sets. And what can are there things that we can share, learn from each other? And so those ones are always really interesting. And then requests, we've had a couple of requests to like translate the core competencies into other languages and like use them, particularly I think those often within schools or public health programs in other countries where they're looking at how they might do some of those assessments with their students and things like that. But yeah, I would say those are probably the biggest categories.
Great, great. Who knows what's on the horizon? Thank you so much for a great overview.
No, and I see someone put in the chat box they're working with the EU and using our competencies. If you want to talk about that, Esther, just let me know. We're happy to chat, and we're happy with all of this stuff. We're happy to share everything. essentially that the council does, and all of the work related to the core competencies is open. So we have lots of stuff on our website, but if there's anything that we can discuss, share, that would be helpful, of like how we go through the process, what have we learned from doing this for the last 20 years, we're always happy to do that.
Kathleen, haven't we learned that pizza is very unhealthy?
It takes a lot of snacks to
Right.
revise the core competencies. Is that what you're saying? Sometimes there's some late nights and some weekends. And pizza is healthy for the soul.
There we go.
You gotta draw that line somewhere.
Yeah.
You need a thing to keep you going. But yeah, definitely reach out, Esther. I'd be happy to talk. That'd be awesome. Okay, any final questions before I turn it back to Bill? Okay, if you think of any, feel free to dump them in the chat box and we will get to them as we go along. So I will turn it back over to you, Bill. Thank you.
All right, Kathleen, thank you so much. That was a wonderful summary. I appreciate it. And I think we all should just once again note how much work you put into this and how much we appreciate all that you do. You have become the center of the competencies and in many ways, the academic health department learning community as well. Now we're going to move on to another subject. We're going to ask Ron to lead this. We're hoping to have a discussion among council members and others to about what the council's potential might be for rebuilding the public health workforce and moving forward now in a sort of newer world or different world. So Ron, you're on.
Thank you so much, Bill. This is an exciting discussion for us, and I hope people feel comfortable putting themselves on screen, so we can see you as we discuss this. But as Bill mentioned, the world has changed considerably, and in particular, since the last time the Council on Linkages developed its strategic goals that were for 2016 to 2020, they weren't revised for a whole variety of reasons. One being that we had reduced funding for a period, and another being that there wasn't necessarily seen a need to do that. Well, given events of COVID, given what we've learned about the needs of our workforce, given the attention to the workforce, and frankly, the new investments, in particular from the federal government through CDC in the public health workforce, it struck us that this is the time to revisit where the council is and where and how we move forward. And hearing from you is critical. We started the discussion, as Kathleen had mentioned, at APHA, hearing from members of the community, and we're looking to continue that discussion today as we think about revisiting the strategic directions and as we also think about funding in the future for the Council on Linkages and what it is we do request. Next slide, please. But before we charge ahead, I thought it would be useful to just give a little bit more perspective of where the council has been and what the council has accomplished over the 30 years. So I'm not going to repeat what Kathleen went through and only really give some big highlights here. Early on, we had an initiative that looked at the feasibility and desirability of evidence-based public health practice guidelines. And we demonstrated that that was feasible and desirable, which then led to CDC creating the Task Force on Community Preventive Services and the Community Guide. We look at that as a real major success, and also actually led to Lloyd Novick beginning the Journal of Public Health Management and Practice. Promoting public health systems research. Way back, we developed a research agenda and actually developed a few research agendas that some of the researchers began to use as they sought funding and as they were conducting research. And actually some doctoral students used it as well. Building the evidence related to the public health workforce. We did a survey on recruitment and retention, where we heard from about 12,000 public health workers. This was done in 2010. And we learned a lot about why people enter public health and why they may leave public health. And that was an early survey done to really educate us on some of what's going on with the workforce. Supporting academic practice linkages, Kathleen mentioned the academic health department learning community, so I won't go through that. And then focusing attention on foundational competencies, the core competencies is that example. Next slide, please. So let's spend a few moments looking at our current strategic direction. So we revisited the council's mission statement. This is what we tweaked along the way. And three key elements here: fostering, coordinating, and monitoring collaboration amongst different types of organizations and even different sectors. Promoting public health education and training as a lifelong learning activity. And then also advancing innovations and innovative strategies to build and strengthen the public health workforce. And that's a lot of what we're talking about now as well. Next slide, please. So what about the values that we articulated along with our strategic directions? A value for the council members is teamwork and collaboration, working together to identify solutions, focusing on the future, so learning from the past, learning from the present, but focusing on the future, bringing partners and people together to have discussions, to develop consensus. Creativity and innovation. Let's think a bit outside the box. Results and creating value. So we're not looking to do things just for the sake of doing them. The value of the council, a big value of the council, is saying that we're going to look on what creates value and what can help results be achieved. And of course, health equity. How do we do this in a manner that promotes health equity and pays attention to it in everything that we do? And then being responsible, being good citizens of the public health community, being accountable to the public health community. Next slide, please. So we also came up with 4 strategic goals or objectives. One is to foster collaboration. Second one is enhancing public health practice, education, and training. Third is supporting development of diverse, highly skilled, and motivated public health workers. And then promoting and strengthening the evidence base for public health practice. So that's what the Council on Linkages came up with and voted on and approved in 2016. Next slide, please. So I thought we'd spend just a little bit of time talking about some of the activities related to those strategic directions. So with fostering collaboration, Kathleen talked a good bit about the academic health department learning community. We also, using the core competencies, develop population health competencies to speak to some other sectors, those working maybe outside of public health, but within population health settings like hospitals, community health centers, and others. Enhancing education and training. Core competencies clearly fit under that, but also we, working with the council, we actually had a task force looking at providing guidance on improving and measuring the impact of training. And I, by the way, intentionally put hyperlinks in here so that some of you may not be familiar with all of these, and you, in accessing the slides, can go to these resources. Supporting workforce development. Again, core competencies are a big one there, but also our recruitment and retention survey. Knowing what it is that influences people to choose to come into public health and stay in public health is critical for us to know, especially again now. And then strengthening the evidence. We came up through the learning community and with the council and academic health department research agenda. So we've had a number of activities around our strategic directions. Next slide, please. So as Kathleen mentioned, current priorities have been the core competencies, the academic health department learning community. And we also more recently, really over the last year and a half or so, have been bringing attention to revitalizing the public health workforce. And on that one, I thought I'd speak just a moment about that. Next slide, please. So what is some of what we've been doing? We've been providing a forum for discussion. We've invited those who wish to come into the meetings to come into the meetings, to share ideas, to share what we know is going on. We had CDC provide a preview of this nearly $4 billion notice of funding opportunity to strengthen public health infrastructure, with about 90% of the funds devoted to workforce development. And by the way, as of yesterday, CDC did put up on its website the notices of award related to that, or the grantees, if you will. Currently, for state, for local, and territorial health departments, 107 health departments are directly funded by CDC, over $3.1 billion currently. That's potentially going to increase. And those are the health departments who've been allocated funds or been granted funds. In addition, 3 national partners having been awarded funding in the total of $65 million thus far. And lo and behold, all 3 are members of the Council on Linkages. And congratulations to ASTO, NNPHI, and FAB. We know that you'll make great contributions to helping the health departments be successful in this workforce development effort. So there's the NOFO. We've also heard of initiatives from CDC, NACCHO, ASTO, and others looking to continue that. We talked about the CDC new training plan of 65 trainings that have been curated and put into an intro to public health practice training plan that uses 6 of the 8 core competency domains. Most recently, we had a presentation from Judy Monroe from the CDC Foundation talking about their lessons learned from hiring more than 3,000 individuals throughout the COVID pandemic. The purpose of that discussion was to give us ideas as this $3.1 billion that's out there for health departments where they need to be hiring people, ideas on how that could be achieved. And then we also heard from Megan at Lincoln at HRSA about the Regional Public Health Training Centers initiative, which is meant to support what it is health departments are trying to do in workforce development. So we're excited about what we've been doing. Next slide, please. Now it's really time to hear from you about what we should be doing within the context of the framework of the council. Collaboration, building consensus. As I said during APHA, we're not looking to develop 100 pages of reports. We're looking to develop consensus and help to facilitate action. Next slide, please. So to get us started, here were some questions. Moving into the future, we're thinking we should continue providing assistance around the use of the core competencies, developing more tools, resources, etc. Again, what do you think? We also have thought that assisting with forming and enhancing academic partnerships is something we should continue. We've been hearing from the community that that's beneficial. With regard to revitalizing the public health workforce, there are going to be a lot of lessons learned, a lot of potential case studies. Is that something that we should be looking at potentially engaging in? Fostering effective recruitment and retention strategies. We have believe it or not, a recruitment and retention work group, right, Kathleen? Is that the right name? That's been on hold really since we did the survey. And then also, fostering efficient systems in public health. We know that there's limited capacity often at the local level. How can that be leveraged in a way where maybe there's more sharing across jurisdictions, more combining of health departments, things of that nature, and of course, other. So I'm going to be quiet for a moment. And Kathleen, don't say anything that you don't believe I can't do that. But let's hear from Council on Linkages members as well as guests. What do you think? What is our focus moving forward? I know somebody has something to say. Thank you, Terry.
Okay, Ron, I won't make any snide remarks about you being able to be quiet. So, but anyway, Ron and Kathleen, thank you for putting this on the agenda. I think that's a great and very timely discussion. I've been having discussions with colleagues, around workforce development and direction and so forth. And I think one of the things that keeps coming up is developing a multi-year plan to build trust back in public health. I mean, I represent NACHO, and we've taken a beating in the last couple of years, and we're not held in high regard. And I think we need an overall plan across all public health to start to build trust back in our public health system. And workforce is going to be a big part of that, I believe. I think if we look at our core competencies, we look at the work that the foundation and others have done, public health schools and so forth, around the science of public health. I think we're in pretty good shape there. But I think on the art of public health, that's an area that's failing for us. And I know we address it in our core competencies. It's at the very, very end. If you have to get to the end, it's 8.7 and 8.8 about engaging politicians and policymakers, advocating for public health. I think that's an area that I would hope there will be resources, training, and so forth moving forward to really, to be more politically savvy, to being able to promote public health, be able to promote your health department. NACHO, I think to their credit over the years has had several programs like Survive and Thrive for new health officials and adaptive leadership. But I really think there needs to be the investment in that more of the part of the art of public health. I mentioned, and I said this in jest, during our discussions, but I said, we need to do a seminar on how not to get fired. That's very real life. When you look at NACHO health officials, there's been almost a 50% turnover in health in our leadership in local public health. And a lot of that, I think, is frustration and some getting dismissed because we haven't really centered on promoting public health and building trust in it. So anyway, I'll be quiet, Ron. But anyway, that's a thought that's on, I think, on a topic right now in Wisconsin in our public health workforce. So thanks.
Great, thank you, Terry. And we are noting everything in this discussion. So please keep it coming, both chat and live. Paul.
Can you hear me? Can you hear me, Ron?
Yes, we can.
Okay, sorry, I'm having some difficulty. Thank you so much for all you're doing. And I just wanted to add on to Terry's sort of congratulations for the good work. I guess a couple thoughts that I've had. One is sort of as the council's representative from ASPPH and the chair of our practice committee, I would love to see a sort of a reintroduction of the Council of Linkages to academic public health, and in particular thinking through perhaps having a special presentation at our practice committee, but also perhaps even some greater visibility with our board of directors. I would dare say that we've also had a fair amount of turnover amongst our deans and program directors, and I would be surprised if the majority of people even are aware of the Council on Linkages in terms of the work that's been done and the great things that you've done with the competencies. And in particular, one of the things that I would love to see is a much greater focus in our schools and programs on encouraging and training people for work in governmental public health. That percentage of people trained with a master's degree in public health or even with other degrees of people actually entering into governmental public health jobs has been diminishing over time. And I would love to think that perhaps part of what we might be able to do together is think through ways in which to sort of invigorate the governmental public health focus. So anyway, that's one of the things that I'd like to just throw out there. The other is the continued work in academic health departments. And although I know there is no funding, at least currently, for this, I continue to believe that these partnerships are so important. And so you've been the only organization really that's sort of continued to be the standard bearer for that work. And I would love to see that continued. And the last thing I would say is that we're working and seeing more and more as health systems are emerging into value-based purchasing and engaging sort of in the next level community benefit work, which necessarily includes focusing on population health. And many of the things that I think that we've been doing at the council could be of interest to our health system colleagues. And again, my orientation has always been around how do we build a strong public health system. It includes our governmental public health agencies, but also others in the community that contribute to it. So that's my 2 cents. Thanks.
Great, thank you, Paul. I should mention that Emily Burke at ASPPH reached out to Kathleen and me about how do we work more closely together? How do we get more of this on the agenda of ASPPH, the academic caucus, et cetera? So yeah, so that's super to hear that there's a dean who's really supportive of that as well, because we know that the deans are critical in all of this.
Yeah, absolutely. Thanks, Ron. And also Emily's a great partner, and I think there's a lot that we can do together. So thanks, Emily.
Great. All right, Bill, I see, Bill, you don't have to ask for permission. You're the chair.
Trying to unmute myself here. Thank you. Well, I just want to be part of the conversation on this. You know, I was a local health director for 3 decades, one in a rural consolidated health department and one in a city health department. And it seems to me that there is a sort of 800-pound gorilla or an elephant in the room that we tend not to discuss, and that is the real limitations we have with so many small health departments that are too resource poor to actually begin to meet the definitions now of what we're saying health departments should be capable of. So I'm wondering if some of the lessons we've learned in the academic health department learning community might be applied to the idea of consolidating local health departments. I know that's a politically charged and difficult personal issue often, and I'm not suggesting the council should be in the position of recommending that necessarily, but perhaps we could do what we've done for academic health department partnerships in terms of finding tools, recommendations, approaches that might be used for those health departments who are interested in pursuing consolidation at the local level. In Kentucky, when I was there a long time ago now, the state health department actively encouraged consolidation and provided extra resources as an incentive, for example, to make this happen and create Kentucky's system of now regional or district health departments. I finished my career in Ohio, where I spent most of it, where there was absolutely none of that, with very little public funding available for local health departments, although we had 5 studies recommending that it happen. That is, that there be consolidation of many small local health departments. So I just wondering if that's something the council might be able to do in a way that would provide a little bit of support for individuals and organizations that might be so inclined.
Great, thank you, Bill. You know, something I didn't mention before is that as individuals are coming up with their thoughts and suggestions, feel free put any of your thoughts related to that in the chat box along the way, just so that we can capture any sort of reactions, if you will, to what people have. Christine.
Hi, everyone. I'm Christine Bean from APHL. I thought I'd share a couple of things we're working on that are related to these questions. And with our new fellowship and internship expansions, major expansions for the Public Health Laboratory, we are using core competencies for fellowship curriculum and constantly using that and weaving it into the curriculum, which is a standard for all of the fellows. Hundreds of them now. And we also are very fortunate to have hired a manager for academic partnership. So we have a person dedicated, Dr. Dana Baker, who's on this call today, to forming and enhancing academic partnerships across the country, and in many cases, targeting minority serving institutions. So we're very proud of that. We're also revitalizing the new lab director orientation. So this was something that was offered last in 2017. So we have over 60 people in that group right now. We're having our second meeting this week. It's going to be a 1-year-long program. And I have had questions from CSTE because they're interested in doing a similar thing for the EPIs. And so we're certainly willing to share what we're working on there. I thought I'd share that today.
Great, thank you so much.
Thank
and
you.
Please, other members, feel free to share that type of information as well with us. Lil, still can't see you with ASTO next to your name.
Can't keep me straight. I am with ASTO, and John Weissman is also the official rep, but as a guest, I wanted to put out a couple things. First, I want to second what Paul said earlier about getting more people interested in governmental public health. I think with your roles in academia and reaching students, we could have a lot of success. Also want to point out some good news. Since launching publichealthcareers.org, which is only for governmental public health positions, the site has been live, driving traffic to the site for a month. We have 28,000 unique visitors to the site. I don't know about you, but I think that's a huge success in terms of, wow, people are interested in governmental public health. I'm hoping that's what it's saying. So I know that many of you were part of that drive to it and really excited about that. More to come with all the recruitment efforts after the CDC infrastructure funding is out. The second thought on some of our work in the Council of Linkages is I think we should continue to work with our funders, but also really take a serious look at funding streams. I know this is a high in the sky, root cause kind of thing, but it has so many effects on not only ASTO members, but public health systems in general. So looking at root causes and trying to get more sustainable funding. The third one and the last one is this, we've had this global pandemic and we still aren't getting public health titles or jobs counted in Department of Labor or Bureau of Labor Statistics. It's not only a national failure, but it's an international failure. Nobody's really enumerating these public health jobs. And I know that there's some momentum from Heather Krasna and other partners. So it wouldn't be, us coming up with something, but maybe partnering and bolstering that initiative. I loved Heather's idea that, we have these medically underserved areas. What about public health underserved areas designations? I'll leave it at that.
Thank you so much, Lil. And yeah, it's interesting that you mentioned the Bureau of Labor issue. I just had that discussion 2 days ago we were talking about, could there be a registered apprenticeship in public health or a series of them? And a registered apprenticeship is based on competencies from the SOCs. I always forget the classification code from the Bureau of Labor. Well, how do you have an effective apprenticeship program that has the competencies that aren't even part of the Bureau of Labor? So we talked about, could we do something to help promote that or push the Bureau to actually give more consideration to public health profession?
That's
So
great
thank you,
to
Bill.
hear.
And I'd be happy to follow up with you on that, Bill. Magali.
Hi, it's always good to see you all again. I am happy to hear all of the good ideas and everything. I think that the Public Health Foundation does a fantastic work with the core competencies and the workforce, so I applaud all of your efforts. I am a little bit, I haven't been able to attend these meetings all the time, so I might be behind in the news and updates that you're doing, but my pitch for today would be, let's try to connect equity to everything that we do. Because when you hear health equity, then it seems like hearing about climate change. It's like so big and you don't know where to begin, that people kind of get frustrated and they don't do anything about it because they think that it's unmanageable, such a huge idea. Where do I begin to do something about it? So because equity is now at the core of the 10 public health essential services, and everything that you are doing, the core competencies, everything that you're doing about workforce, everything has a relationship with equity. So I would like to see if there is a way that we can highlight the equity effort or the equity angle with everything that we are doing, because that I think is important. That will help the entire public health community at departments of health, at universities and everywhere. And I don't know if there's a committee, I don't know if there's anything else that has been happening, but that will be my pitch. And all of the other ideas that were presented by other people are very good as well.
Great, thank you, Magali. You know, and we've avoided using the term looking at things through a health equity lens. So I always fear, or we always fear, that health equity then gets lost. It has to be very explicit in what we do, and that's a good reminder and something for us to strive for as we continue moving forward with the council work. Thank you. Claude, always good to hear from a local health official.
Hey, Ron. Good afternoon to one and all. Can you all hear me? Fantastic. Bidding you greetings from sunny San Antonio here in Southwest Texas. Really appreciate your pitch, Kathleen. Just thinking about the global questions you have slide, Ron. I'm just thinking about the second one and the fifth one in terms of the role of the council. And I'm a guest here, so I don't have an assigned role, but full disclosure, I did serve on the PHF board and also served on the NACHO board, and I currently serve on the FAB board. So again, in my spare time, obviously fulfilling my governance roles on these national organizations. But what the conversations I'm hearing on the ground, I do see an opportunity for the council to be the Uber translator in a couple spaces. One is thinking about Bill's point about the contrast of the governmental public health enterprise, speaking from the vantage point of local health departments. So you have small, rural, frontier health departments and the contrast with the larger urban nodes. So I'm at a large urban health department. Our district reach is 2.1 mil for the city of San Antonio and the greater Bexar County. But our needs, our workforce needs, make contrast with the smaller, less resource health departments. So the council could serve as a repository just to translate the context. And I know that NACHO, we do that through our state associations and through the role as the membership association. So that's one role that I see for the council, is to translate the context of our workforce needs. Paul mentioned, again, the rate determining step. Again, part of the reason that you don't see a stampede to health departments, speaking as one of many, is that we just don't pay enough. And so whatever it is that we can re-engineer in the ecosystem, demonstrating value for why it's a cool discipline to join, again, the council can serve in that space to convey that. So that's one dimension. The other, in terms of collaborations on the ground, again, I've been here a year and a half, and here in San Antonio, our city, again, academic partners, the UT Health Sciences Center and the University of Texas at San Antonio, also known as UTSA, they went through a study and realized that we don't have a freestanding, standalone school of public health. So we are now, again, on this journey to establish a collaborative school of public health here in San Antonio. And that's going to open and accept students starting in the fall of 2024. But what I do see is that the council can continue to be the translator of the practice of public health. So Terry, your point about the art, I'm with you 100%. And I do feel that this body or this learning community can help demonstrate, well, what does it mean to have this real world public health experience, and what does that look like? So just acknowledging that in terms of this discussion. The last thing is, and this is sort of the wish to the genie, we have CEF, we now have, over the last 15 years or so, anchored to FAB, at least a conduit recognizing the value of these accreditation experiences. But there doesn't have the formal way to recognize academic health departments. And I recognize there may be complexity to that, but just know that that could be an opportunity to articulate what does that actually mean? So that to me is a place that the council can amplify that. I use the term here, and we're still trying to figure out for ourselves what that looks like in our ongoing collaborations with partners on the ground. So long answers to your main questions. I'm a card-carrying fan of Kathleen's work, and so just saying thanks for the invite, and it's good to see a number of you all virtually. And Rex, it's not lost on me what shirt you're wearing. I know what just happened this past weekend. Just saying, I see what you're wearing.
Thank you, Claude. And with regard to your second comment about formal recognition of academic health departments, when we started this effort, we came up with a draft of what the definition might be. And it's remained a draft over the years with the intention of revising it over time. And the reason why it was a draft initially was we said to ourselves, who are we to say what these really are? But to your point, I think we've learned a great deal over the years, and that we probably can start refining that a bit more so somebody can say, I am one, or I maybe am not, or maybe I'm on the way to becoming one. So something for us to consider. Thank you. Rex. You are on mute. First time I've ever got to say that to you, Rex.
Oh boy, yeah. Read my lips, no new taxes. But I'm putting up this slide because I think Terry, in some of his comments early on, were hitting where I was and am. And I actually go back and forth on, do we need to teach health directors how not to get fired, or do we actually need to teach them how to get fired because they're actually taking the risks that are needed to move public health forward? But regardless, when we look at this EPI 2x2, and whether it's, you're meeting your accreditation standards or your business plan or quality improvement, if you think about a lot of fire departments as an example in metro areas, they get a little bit more money when they're doing a pretty good job. If fires increase or there are various challenges in getting their services done, they often get a whole lot more money. And why? Because they're up above that line, their perceived value, trust, reputation, community support, political clout is high. And I don't think we do even 5% the job that we need in preparing public health professionals to do this work to move us above that line. Because what happens in a lot of local health departments is if they achieve what they were expected to achieve, then the elected officials say, well, can you do that on a little less next year? And then when we have a pandemic like we've had in many communities, where they were perceived as not having been successful, then they're starting to lose their mission, their CEO, etc. So to me, this is the fundamental thing of how do you build power in your community? How do you organize? And then the other one I want to put up here is Colin Powell's probability 40-70, where, yeah, if you act before you're 40% certain, you're probably not a good idea. But if you wait till you're 70% certain, then you've missed the opportunity. And in public health, I think most elected or appointed health department officials are up there in the P95 to 105 range. And, you know, during my 23 years, if I wasn't in that 50 to 80 range, then I would have considered I probably should do something else because I wasn't going to be effective. So, you know, I do think we need to train public health folks on how to have and live within your means so that if you get fired, you can find another job in the next year that, you know, you can make it. So I think there's a lot of training that we need to have so that people aren't scared to lose their job.
So Rex, we'll look forward to you coming up with the course, How to Get Fired in Public Health. All right.
Yeah, that might be a good book title. I was thinking about risk-taking leadership in public health, but now you've kind of convinced me maybe there's a better title there.
Sounds good or bad.
Or how to be a phoenix and come up out of the ashes.
Well, I see our time, we're a little bit over. Let me ask if there are any more observations, suggestions people have before we move on to our next agenda item.
I would just encourage people to check out the chat box as well if you're not following that, because there's lots of comments in there also.
Yeah, I've seen a lot related to trust in public health, as the most recent chat comment noted. Okay, well, and also following the meeting, as you've thought about this further, please send us your thoughts, your comments. You know, I didn't hear anybody object to the thought of us continuing work with the core competencies and academic health departments. That seems to be reasonable. And all of the rest is, there's still a bit of TBD. So Bill, how about if I turn it back to you?
All right, Ron, thank you so much. And thank all of you for your participation and for your listening carefully. As Ron said, let me also encourage you as you process this to drop us a note about any other thoughts you have that might be helpful to us. It will be an issue for the council this year as we move forward to figure out what our strategic objectives should be for the future. And we do that best when we get help and input from all of you. So thank you so much. And now to move on, I'd like to introduce Vanessa Lammers as Director of Performance Management and Quality Improvement at the Public Health Foundation to introduce a discussion now about how practice and academia can help increase flu vaccination, a topical subject. Vanessa, are you there?
Thank you so much, Bill. Good afternoon, everyone. That was a really wonderful, robust discussion. I'm sorry to take us away from that. But we do have a pressing matter of our current flu season going into deep winter. As Kathleen mentioned at the beginning, we are very ahead on flu cases and very behind on flu vaccination. So with that, I'm going to introduce my two colleagues, Alicia Budd and Aaron Burns from the CDC flu team, to talk to us a little bit today about how academia and practice can work together to increase flu vaccination and try to keep us all safe this winter.
Hi, this is Alicia Budd. Vanessa, would you like me to go ahead and get started?
Yes, please.
Wonderful. Well, thank you so much for inviting me to talk with you all this afternoon about what in the world is going on with flu activity this year. We had a bit of a break from it for a couple of years with plenty of other respiratory virus activity to work on, but Now we've got flu back in the mix. So I'm excited to be here to talk with you all today. I give lots of flu activity updates, but this is a new group for me. So I appreciate the invitation. Next slide. So usually this is sort of more of my summary slide, but I wanted to stick it at the beginning and sort of tell you where we are, and then show you the data that we use to sort of make these descriptions of the season, how you can find more detail as we go through, in case that is of interest to you as well. So the highlight, which all of you are very well aware of, is that we are seeing early increases in flu activity compared to usual. I have usual there in quotes because there really is no usual flu season, but regardless of how you define usual time for activity to increase, we certainly got a head start on that. The other thing to point out is that while there is no doubt that activity started early, we don't yet know how bad ultimately the season will be. And I'll show you some seasonal comparison data that points this out. But that is why we still have to keep an eye on what's happening. But while I say, we don't yet know how bad it is, even where we are right now, you can see there on the screen, I won't read you the numbers, but the burden of flu so far this season is already significant. So we have a lot more to come, and we're already seeing quite a bit of burden. And the other thing, which I'm sure you've also heard about, is this twin-demic, triple-demic, whatever you want to call it. Flu's not out there by itself right now, and so that's really causing more angst in the healthcare system. And then, as we mentioned, it's a great time to get vaccinated, and unfortunately, it doesn't look like quite as many people are as we would like to see. Next slide, please. So here are some of the data behind what I'm talking about. And we have a lot of different ways that we monitor flu activity. I'm not going to go into them all for the interest of time, but did want to show you some highlights this afternoon. So on the top left is data from clinical labs that look at and report to CDC the percent of specimens that they've tested for flu that are positive. And you can see there a little bit to the center and right of the screen, that sort of spaghetti line of different colors. Those are past seasons percent positivity trends over time. So this is why I say there's no usual flu season. It's all over the map in terms of intensity of peak and timing. But there on the left, getting a head start in red is this season. So there's some of the data to show just how early activity is increasing this season. Below that is data from our public health labs, where we get more information about the specific viruses. We are seeing almost exclusively influenza A viruses this year, and a mix between H3 and H1, though predominantly H3 at this point. And then on the right, we take a subset of the specimens from the public health labs. They get tested at CDC reference labs in more detail. So we look at the genetic data, we look at the antigenic data, and we also look at markers of antiviral resistance. And thankfully, the picture here all looks good. I won't go through the numbers, but the viruses tested look very similar genetically to the viruses in the vaccine this year. Very similar, behaving very similar antigenically, and we've not yet identified any antiviral resistance organisms. So at least we do have that going for us so far. Next slide, please. Here are just some of the systems that we look at to monitor impact of activity. On the left is long-term care facility flu data. And below that is hospital admission data from a nationwide system. Both of these we being flu, piggybacked onto some COVID systems that were set up. And so we're still continuing to use those data now. And on the right is data from a system called FluServeNet, which is our longstanding flu hospitalization system. It's population-based rates, but it's only in a small subset of the US population. It's across multiple states, but it's about 9% of the population total. but we do get a lot more detailed information about the flu hospitalizations here. And all three of these systems look at laboratory confirmed influenza. So what the issue to point out here again with the hospital data on the right is you can see this season there in red compared to prior seasons, and this season, you know, off to an early start. But what you can also see there, and this is cumulative rates for the season by week. So you can see that while we are certainly off to an early start, that where we are with rates right now is certainly on the low end of what we would expect to see by the end of a typical, again in quotes, typical flu season. So we just have to see where that's ultimately going to end up. And you can see there below the numbers behind the differences in rates where we are right now in the season and where we typically are at this point in the season. And you can see here I'm showing overall data, all ages combined, but the story is similar. Even if you break it down by age groups, all of the age groups are seeing higher rates now than we would expect them to see. Next slide, please. So this last activity slide is really, so I could make the point, many of you may see different maps, this data in particular, and it's often referred to as flu data, and really it's more broad than that. This is our outpatient respiratory illness syndromic surveillance system. So here we're looking at outpatient providers or emergency department visits for people with fever plus cough or sore throat. So certainly pre-COVID, it was a very good indicator of flu activity. We knew that it would sometimes pick up RSV, but seasonality was usually different enough that it didn't cause too much trouble. Well, now that COVID's on the scene and the other respiratory viruses are a little off on their seasonality, this is certainly picking up flu still, but also picking up other respiratory viruses. So just to point out here again, the top left, this is overall all age group national data. You can see, you know, this season is early and high in terms of ILI activity compared to the prior, you know, different colored spaghetti of prior seasons. Below that, you can see age group data. The orange line, the highest, is the youngest children, 0 to 4, followed by the 5 to 24-year-olds. So this is what you're hearing a lot about, where RSV is impacting it quite a bit as well. And then on the map on the right is, again, the same data, but on a geographic distribution. And we've been, of course, monitoring this over the season, and we've seen these darker colors, which are indicative of the higher levels of respiratory activity, sort of expand as the flu virus or the flu activity increases have expanded across the country. But like I said, we also know that we're seeing a lot of RSV, we're seeing a lot of rhino-entero. COVID certainly hasn't gone away. So this is picking up a lot of things, including flu. Next slide, please. So here again is sort of the take home point on flu activity right now, is that it started early this year, as we've talked about, and it's not alone. And I won't go through this all again. Most of it's what we've already talked about, but did just want to point out RSV timing. I'd mentioned how some of the respiratory viruses are still, I don't know, we like to perhaps personify them a little, but it's almost like they're still jockeying for position out there in a COVID world. And RSV doesn't seem to have figured out exactly where it wants to land right now. Pre-COVID, RSV would typically peak in December or January nationally. Then in 2021, it peaked in August. This year, maybe we've peaked at some point in November, but we're still waiting to see. So a lot is still in the mix right now, but one thing is for certain is that flu is definitely back. So next slide. So all that to say, so flu is increasing early, but what about vaccine uptake? And we're, you know, it's concerning to see that there are some lags that appear based on some of the data that we currently have available. That would be concerning anyway, but it's particularly concerning given the levels of flu activity that we're already seeing. So these graphs here just show you some data. This is claims-based data from people who have received their flu vaccine in a pharmacy or in a physician's medical office. And these are claims data. So, there's a lot to keep in mind with these data. Claims data can lag. These data are not covering vaccine that has been administered in a different setting, for instance, a workplace scenario where a claim may not be filed. But it is concerning enough to see that here we have less vaccine administered at this point in the season than we did last year or the prior year. So again, with the early increases in flu activity and these somewhat lagging numbers here, it's definitely enough to be concerned. Next slide, please. And then this just shows a couple more coverage, a couple more graphs of coverage data of specific groups. So on the left, you see children 6 months to 17 years. The source here is different than the adults we just looked at. This is the National Immunization Survey. And overall, you can see that coverage for children is similar this year to last year, though down a bit from 2020. And that there is discrepancies or differences depending on the racial and ethnic groups. So higher coverage rates this season in Black, non-Hispanic, and Hispanic children, but lower among white non-Hispanic children. And then another group of particular concern are pregnant women. So here you can see that for pregnant persons 18 to 49, there's been this steady decline in coverage over the past 2 years. The specific numbers are there on the slide for you, and that the 2-year decline has seen across all of the racial and ethnic groups. The extent varies certainly, but that unfortunate pattern is the same across all the groups. Next slide. So that just sort of lays the groundwork for why we're concerned, what activity is doing, and also what vaccine coverage looks like. Here on this slide are just a couple resources if you're interested in looking at what flu activity or vaccine coverage data are doing on a weekly basis. All of that information is updated for the flu activity data. It's updated every Friday at 11. The vaccine data is also updated weekly. And I'm not sure how we're going to do questions, but I'm happy to take questions at any point. But what I've done here is just sort of lay the groundwork for my colleague, Erin Burns, to talk about the communications plan to try to address these concerns. Thank you.
Hi, thanks, Alicia. As Alicia mentioned, my name's Erin Burns. I'm the communications lead for the flu division at CDC. And I guess this is the 3rd year that I've helped direct the campaign activities for flu vaccine. And so I just wanted to kind of highlight some of the communications resources that we have available and encourage you all to make use of those if at all possible to help us sort of continue to promote flu vaccination as we go into the holidays and beyond. Next slide. So we do annual flu campaigns, and those launched in late September. I think we had a series of launches. We did a big media event with the National Foundation for Infectious Diseases. Where we had Dr. Walensky give the keynote address. We also have 2 campaigns that are going simultaneously. One is a campaign that focuses especially on parents, because as Alicia pointed out, we've seen since the pandemic started a drop in coverage among kids of about 6 percentage points. So there are one of our main target audiences, although we are also especially concerned about pregnant women, people with chronic conditions, and older adults. So we do have assets to promote vaccination among all of those groups. These are just some slides that I'm sharing to give you an idea of the kind of preliminary impact that we had with the original campaign launch. Next slide. So this is the NFID press conference, where, as I mentioned, we had a lot of media coverage. I think one of the ways that we do try to get the word out about flu vaccine is through the media, because of, I think, ongoing COVID activity and RSV activity, and with the elections, it was a little bit harder for us to gain attention, but we did still see quite a bit of coverage that resulted from this original kickoff. Next slide. And then the other campaign that we have going is year 3 in a collaboration that we've been doing with the American Medical Association and the Ad Council. So they also launched their activities in the middle of October. These are just some of the metrics from their campaign. Next slide. And then another thing I wanted to draw your attention to as a resource is on October 18th, CDC put out a vital signs, which includes an MMWR and then a web report that looked at flu burden and flu coverage by race, ethnicity in the United States. So, what we found was that among certain minority populations, there's a higher burden of severe illness for flu, and then they are less likely to get vaccinated as well. And so this report sort of looked at some of that data and explored what the reasons might be for those disparities. And so if y'all weren't familiar with this piece that came out, I just wanted to point it out as kind of a very interesting and I think useful resource. Next slide. And so these are, as I mentioned, our main priority, a target group is parents and trying to convince them to get their kids vaccinated. The collaboration that we did with the marketing group Weber Shandwick, the theme of this was sort of help them fight flu. So we have corollary pieces. I mean, we have pieces that focus on kids, but we also have corollary pieces for our other target groups. And next slide. I just want to kind of highlight some of the resources that we have available. So on the last slide, there was a link to our website where you can get all these assets. And we have like cleared social media, we have infographics. There's all kinds of tools that people can use to, get out there themselves and try to promote flu vaccination. And then this season for the Ad Council, in addition to updating the assets that we've done for the previous 2 years, we also filmed some videos that are kind of real world doctors answering common questions that we found among people in our focus group research. So, so this is also an asset where doctors themselves are answering patient questions, and this could potentially be of use to you all as your Gesundheit, as you're, trying to get the word out about flu vaccination. Next slide. And so then, as Alicia mentioned, when we started to see this increased activity and the sort of lag in vaccine uptake, we have been doing a lot of additional outreach. We put out a health alert. We did a press briefing. We've been doing a number of webinars along these lines, just trying to make the point about the importance of, ongoing flu vaccination, and in order to helpfully move the needle and, catch up to where we have been previously. Next slide. So another thing that we did was sort of an ad hoc newsletter that went out to different partners. We also sent out partner letters. And then we have a number of kind of fact sheets or flyers that are available for people to use for specific audiences. That's available as a resource as well, if anybody's interested in that. Next slide. And then also just to mention, next week is actually National Influenza Vaccination Week. And so we have a number of new assets that have been produced specifically for that week. We're also doing new outreach through micro influencers.
And we have a bylined news article that's coming out. But if you go to the link on this slide, you can, that'll take you to our National Influenza Vaccination Week landing page where we have our specific assets for next week. We also have a media roundtable planned for Wednesday, where hopefully, we can get the word out about the importance of vaccination as well. Next slide. And I just wanted to kind of share with you also where we are with our key messages, right? And, as Alicia mentioned, there's a lot of flu out there. We're starting to see increases in our severity indicators. And we have had at this point already 12 pediatric deaths reported to this season. The good news, as Alicia mentioned, is that most of the viruses that we've seen so far are genetically and antigenically like what's in the vaccine, which is usually good news in terms of vaccine effectiveness. And so I think the main point that we're trying to say to people is that there's still a lot of flu out there. It could go on for weeks or even months. There's more than one flu virus circulating, and flu vaccines protect against 4 different viruses. So even if you've had flu once, it's still worth it to get vaccinated because you could very well be exposed to another flu virus. And so continuing to, try to encourage people to get vaccinated. I think for clinicians, the message is, if you offered vaccine earlier in the season and people declined, maybe try offering again, just because with all the activity that we're seeing later now, people's, risk benefit analysis may have changed. And I think that's it for me, but let's see the next slide. Okay, and then also available here is what we've been trying to do is also what Alicia did in her last slide, which is to integrate kind of preventive messaging for all the different respiratory viruses that are circulating right now. And of course, there's flu, RSV, and COVID. And so these are the overarching, how to protect yourself, get vaccinated, take everyday preventive actions, and then reminding people that for flu and COVID, there are prescription antiviral medications. And I think that I really am done now, but let's check. Yes, I am. Thank you. So whatever you can do to help us get the word out, we'd really appreciate it. Thanks so much.
Well, thank you very much, Alicia and Erin and Vanessa. Excuse me. So what does this have to do with the Council on Linkages? Well, this is, well, not necessarily a crisis today. It's an impending and preventable crisis. And if we think about how academia and practice have worked together to address COVID, there's a wonderful opportunity for us to address flu. So for instance, our academic health departments that we've heard from regarding COVID, and there was a webinar on that about how academic health departments contributed to working with the practice community and the academic community to address COVID issues. And Kathleen, if you could put the link in the chat box, thank you, that's great. So what were some of the things that have been done around COVID? One is working together, digging deeper into the data that relate to the specific community. Another was identifying pockets of low uptake of the vaccine and higher risk groups and doing collective outreach with those groups. So those are just some ideas of how the academic and practice communities can work together to address this potentially impending crisis. So let me ask if there are questions for Erin, Alicia, or any ideas, other ideas people would like to share. I think everybody's idea worn out from the previous discussion. Well, as activity within your own backyards occurs to promote flu vaccinations, and as there are examples of the practice and academic communities working together on this, please share them with us. We'd like to document that. And that's always useful also for future flu seasons and future respiratory diseases as well. Erin and Alicia, anything else you wanted to add?
The only thing for me would be to say, in terms of academic institutions, we have several that participate at a variety of our surveillance efforts, and thank any of you who might be involved in those, because it really is helpful and you know, provides us the information that we need to help educate everyone. So thank you.
Great. Well, thank you so much. And Bill, let me turn it back to you.
All right, Ron, thank you. And thank you to everyone who participated in that portion of our meeting. That brings us really to the end of our agenda. So let me ask if there is any other business the council members should consider at today's meeting. Hearing none, then I'll assume we have completed our agenda. And I'll let you know, obviously, this is the last meeting of the council scheduled for this year. We will be, of course, working to schedule meetings in the coming year. So early in 2023, council members can expect to hear from our staff as we try to find dates that will be attractive to the majority of people available. So wait for that, and please respond promptly so we can move ahead and set a series of meetings for the coming year. And as always, thanks to our staff, Kathleen and Ron, and everyone else for participating today. I think we'll close the meeting then. We'll declare it officially over and wish you all well for the coming holiday season. Be safe out there.
Thank you, everyone.
Right. Bye-bye now, everyone.